is Sarah Littlefield, and I'm recording a teaching strategy of case study and partial fulfillment of the requirements of N5309 Teaching and Learning Strategies with Dr. Susan Ward as the professor and Coach Gloria Menard as my coach. Okay, so today I'm going to present a case study involving anaphylactoid syndrome of pregnancy. From here on out, I'll refer to that as ASP. First, I'm going to explain briefly what it is. It's a rare and catastrophic event that occurs during the intrapartum phase of pregnancy or immediately after delivery. Debris such as amniotic fluid or fetal cells enter the maternal circulation, and they cause a cascade of symptoms that can lead to neurologic impairment or death. There are many theories on its etiology, but the one presented today will be that it is an anaphylactic reaction. Prediction and prevention of ASP is extremely difficult. Some literature states that the prevalence of ASP is 7.7 in 100,000 births, and the mortality rate for the mother is between 80 and 90%. So I'm going to present the case study. A patient in her 20s comes into OB triage, 33 weeks gestation with twins with premature rupture of membranes. A cervical exam reveals that she's in an early active phase of labor, so she's admitted, but she fails to progress, so a C-section is ordered. Her lab work reveals she's hemodynamically unstable. She's had a couple of miscarriages and a few uncomplicated vaginal deliveries. She's taken to the OR and given spinal anesthesia and subsequently medication to increase her blood pressure. All is going well until the first infant and placenta are delivered. Her oxygen sats drop. She becomes bradycardic. Medications are given to counteract this to no avail. CPR is started and more medication is given. A normal sinus rhythm is obtained and confirmed with the pulse. The second infant and placenta is delivered. The patient begins to bleed profusely and is given medications to counteract this. She is hemodynamically stabilized with multiple units of PRVCs and FFP and is transferred to the ICU. She remains there with the diagnosis of anoxic brain injury for 22 days, but she has no brain activity. On the 23rd day, her family decides to take her off life support and she dies. Both infants are discharged healthy and with no neurological deficits after 5 weeks in the NICU. Let's discuss what we know about this case. I'm presenting this to Brent. He's a fellow obstetric nurse. So let's discuss what we know about this case. Could the diagnosis of ASP be confirmed on the basis of lab data alone? Why or why not?
No, because before the C-section, the patient was hemodynamically stable.
Very good. According to the National Registry for ASP, criteria for ASP include acute hypotension, cardiac arrest, acute hypoxia, coagulopathy, or severe hemorrhage in the absence of clinical explanation, and the onset of the above during or within 30 minutes of labor, C-section, or dilation and evacuation. Did the patient in our study meet all of these diagnostic criteria?
Yes.
All right, so what do you think caused the initial insult and subsequent cascade of catastrophic events?
When the first infant and placenta were delivered, amniotic fluid and or debris could have entered the maternal circulation via the placenta separation site.
Very good. And how do you think CPR might be different for a pregnant patient?
Well, I know that the uterus displaces certain organs and compress the interior vena cava as well as the aorta.
Very good. And how might this affect circulation?
It would obstruct venous return and arterial blood flow.
Very good. Let me just go over all the ways that CPR is different with a pregnant patient. I realize that in our case study, the patient in the OR was being delivered, but I'm going to go over the ways in general that it's different for a pregnant patient. So the gravid uterus limits the effectiveness of chest compressions because everything's displaced from the fetus in the enlarged uterus. So you're going to want to do a left lateral tilt, and the hormonal changes in pregnancy promote insufficiency of the gastroesophageal sphincter, increasing the risk of regurgitation. So you need to apply constant cricoid pressure during positive pressure ventilation. For circulation, you're going to perform chest compressions higher on the sternum, slightly above, and which will adjust for the elevation of the diaphragm and abdominal contents. There's really no change for defibrillation except that if they're in a labor and delivery or antepartum setting, you're going to want to make sure you remove all fetal and uterine monitors. And if these efforts are not successful to be resuscitated within 4 minutes, you're going to help the provider prepare for a perimortem C-section. All of this can be best summarized with the acronym ABCDD: airway, breathing, circulation, defibrillation, and delivery. Okay.
Okay, so with a pregnant patient, I would adjust my CPR by applying continuous cricoid pressure during positive pressure ventilation, perform chest compressions higher on the sternum, make sure that during defibrillation any fetal uterine monitors were discontinued. Then, if the resuscitation attempt was not successful after 4 minutes, help the provider prepare for a perimortem pремortem C-section.
Very good. All that's correct. So back to our case study. What were the first signs that our patient was deteriorating?
I think it was a change in the EKG and decrease in oxygen saturation.
Very good. So the initial pulmonary insult, as shown in this diagram right here, would cause transient vasospasm and acute pulmonary hypertension, which leads to severe hypoxia. And why do you think our patient was bleeding so badly?
She was most likely going into DIC.
Correct. This was one part of the catastrophic cascade of events related to ASP and occurs in approximately 83%. And what do you think treatment consists of when a patient is experiencing ASP?
It seems like there may not be a cure for it, but supportive measures could be taken.
Very good. What types of supportive measures did our patient receive?
She was oxygenated via endotracheal tube, and her circulation was supported with medications and CPR.
Very good. She was also given a transfusion to help correct coagulopathy. Studies have shown that rapid delivery of the fetus can improve maternal and perinatal survival. So let's develop a plan of care for a patient experiencing ASP.
Well, based on what I've learned so far, I would present the following plan of care for a patient experiencing ASP. Supportive care with initial insult, displace the uterus to improve circulation, left lateral tilt, put oxygen on the patient, and call for help. If CPR is needed, I'll remember I would adjust my CPR by applying continuous cricoid pressure during positive pressure ventilation, perform chest compressions higher on the sternum, and make sure that during defibrillation any fetal uterine monitors were discontinued. And then if the resuscitation attempt was not successful after 4 minutes, help the provider prepare for the perimortem C-section A, B, C, D, D. I will do everything I can to facilitate a rapid delivery in hopes of improving maternal and neonatal survival.
That sounds like a really good plan of care. I think you learned a lot from this case study.
Thank you. I do think I've learned a lot from this case study.
So to review, and I've put it on the trifold here to kind of help the important points stick in your mind. ASP is a rare and catastrophic event where amniotic fluid and fetal cells enter maternal circulation. This triggers a cascade of events that leads to neurological impairment and or death. There is no cure, supportive measures only. It occurs rarely, only 7.7 in 100,000, and the mortality rate is high at 80 to 90%. And CPR is different because the different things you do with airway and breathing, circulation, defibrillation, and prepare for delivery. And then, we went over our plan of care, which you did really well with. So I've also provided a handout for you if you ever need a refresher. It goes over what it is, an overview of a case study, how CPR is different, and a plan of care. So I also want to go over with you the learning objectives for this case study were be able to apply what you've learned to develop a plan of care and identify the 5 ways in which CPR is different, which I believe you met both of the outcomes. So thank you for your time in this case study.